Just before I get started, I just want to say how much I've been enjoying all these talks. My talk's going to be not so much ideation about the future, but what we actually have. A lot of you are using these tools, and when I was asked to create this talk, I thought, it's going to be a mix of academic and community folks that are here, RADs, technologists. So part of what I'm trying to do is help describe a practical approach to what I do, and as Nirja mentioned, we're just a couple hours west of here, and we have multiple third-party software products that we use, of which Vitria is but one of them. And so it's really important to get facile with these until we get to that stage where a lot of this post-processing is more automated. It still does require a fair amount of manual involvement. So I'm going to be talking about Vitria and how it applies to the cardiovascular part of my practice. These are my disclosures. So beyond PACS visualization. So we, in this part of the world, southwestern Ontario, are about 20 years after the transition away from film to digitization. We all know digitization lets us do all sorts of fancy stuff that we've been hearing about today. But it's amazing, and I'm sure those of you in the audience would agree with me, how much of CT and MR is still largely 2D axial scrolling. We know there's a rich amount of data in what we can do with that data, and we've seen lots of examples of what we can do. But day-to-day, regular clinical work is still largely in the 2D realm, and it's a lot of axial scrolling. That being said, what we are doing routinely happens to be qualitative, but there's been a gradual push to do more and more quantitative analysis by radiologists. And that really does translate to more accurate diagnoses and treatment planning. A lot of this has been driven earlier, largely through cardiovascular disease. And the big reason for that is the burden. There was a Canon commercial that was running in between these sessions. I don't know if you guys saw it, but it was talking about the growing disease burden of cardiovascular disease. And this is one stat. They're talking about at least quadrupling or more, independent of age groups. By 2050, 190 billion for young people and almost 600 billion for the elderly. So really important in terms of the economic impact. Now, as we all know, the time required to provide these accurate measurements has been historically prohibitive. Ravi talked a lot about some automation that's coming down the pipeline from Canon in multiple aspects, including post-processing. And these newer tools that are available through products like Vitria really do reduce the time required to do the post-processing as well as the accuracy. In cardiac imaging specifically, we have a wealth of rich data that's available to us. We're able to measure structure, function, and flow. So quantification of data sets such as this four-dimensional phase contrast MR study not only drive patient management, but actually offer us in vivo insights into human physiology that we actually didn't know about until these were developed. So they're actually very difficult to visualize in any other way. So one of the promises of some of this quantification may be to offer insights that we can't get any other way. So moving on to looking at Vitria for cardiovascular CT. So this offers several tools that I'll be talking about. Different vendors may or may not have similar functionality. The routine clinical cases that I'll be talking about really encompass coronary disease, aortic disease, and peripheral vascular disease. For the most part, I think that's pretty ubiquitous no matter what your practice is. We'll then discuss some more advanced clinical and research applications for myocardial disease, so myocardial function, perfusion, and then we'll look at some advanced ways of doing 3D visualization, which some of the speakers have already shown examples of today. So the image on the right shows several modules that are available in Vitria that we use. And and I'll be focusing on the cardiovascular ones. You can see, obviously, there are some body applications as well as MSK. So, starting off with routine cases. Coronary and aortic valve calcium appear fairly simplistic, but the continued growth in this fairly simple process of calcium quantification will likely extend beyond the walls of academia and require support by community practices to meet the increasing clinical demand for both coronary and aortic calcification quantification. We've heard a lot about the HR challenges, both from the technologist and the radiologist side. So a lot of, we're a regional cardiac referral center. These currently largely come to us, but this is a non-contrast study. There's gated CT in every community hospital now. There's no reason these can't be done out there. And as that HR shortage starts to manifest itself more and more, the need for community partners to really do this will be more and more important. CT angiography in multiple vascular beds throughout the body has become critical in driving management. As we've heard about earlier, CTA in acute stroke is one particularly impactful example of the last decade. A massive amount of data that's been generated, that gets generated, requires a time-efficient tool for analysis. So we'll be looking at the aortic and iliofemoral vessels. All right, so let's start with calcium. Starting with coronary calcium. Coronary calcium is, as some know, is a very, very powerful biomarker. Now, if you go to the Society of Cardiovascular CT, there's sort of two camps. There's the guy, there's the folks who think, oh yeah, calcium is really, really important. We need to use it for prognosis. It's a major, very, very valuable tool. Then there's the angiography folks who say, oh, it doesn't really matter. We just want to know if there's obstructive disease. We've had hints of that as we were discussing earlier today. But the really, really critical point is, on the one end of the scale, if you have a calcium score of 0, your statistical risk of a major adverse cardiac event, that's cardiovascular death, non-fatal MR, non-fatal stroke, based on whether you're symptomatic or not. So if you have stable chest pain, there's some data suggesting about 0.5% over 3.5 years, and 1.7% over 10 years if you're asymptomatic. It's extremely powerful. Conversely, if you happen to have a high calcium score, it's a little more gray. What is known is that a threshold of over 400 units increases your risk of obstructive coronary disease to 76% from 4% with a calcium score of 0. Aortic valvular calcification, unlike the prognostic benefit from coronary calcification, is diagnostic. It's largely used to adjudicate patients who are referred from Doppler echocardiography. So standard of care these days is the non-invasive assessment of aortic stenosis using 3 parameters in echo, looking at the mean gradient, the peak velocity, and the aortic valve area. Ultrasound's an imperfect tool, and so as a result, a lot of people who are referred on for aortic stenosis don't have truly severe aortic stenosis, which is by AHA guidelines what's actually driving appropriate management. I have a whole talk on aortic stenosis I give my trainees, which I could eat up an hour with, but in a nutshell, these threshold numbers that I've put up here from Europe, the Americans have lower thresholds to drive more intervention, we'll put it that. The most important ones for you here are the 2,000 and 1,200 for males and females. So an aortic valve calcium score above 2,000 in a male or above 1,200 suggests aortic stenosis is likely, and that drives intervention. It's really critical for our TAVI patients, which is they're usually trying to decide whether or not it's actually severe aortic stenosis. And lastly, there's a recent editorial that's talking about the possibility of even using aortic valve calcium as a screening tool. So not somebody who's presented symptomatically, and we already know based on echo that they actually have some degree of valvular stenosis, but perhaps, and it's sort of akin to what we were talking about in the neuro discussion earlier, could this be an earlier biomarker when people are preclinical, pre-symptomatic? I think the jury's out on that. But if that actually does grow, it's again really, really critical to have more and more skilled radiologists to be able to do this work. So here's a typical example for coronaries. So you can see it's we start with the finger tool, hit the RCA labeler, and after one click, 1 second. The software is able to segment out the calcium both in and out of plane in the z-axis. So fairly routine, easy, and you get both an Agatston and a volume score from that. Here's an example using the exact same Vitria module for aortic valvular calcification. So I really like this patient example. It's a recent patient that I had to analyze. Not only does this patient have a lot of aortic valvular calcification, you'll notice there's a fair amount of calcium actually around the aortic sinuses, as well as severe coronary calcium. That could be problematic if you're trying to segment out only the valvular calcification, which is what's going to drive that threshold, that quantitative number that they need to make the management decision. So you'll notice how that tool is not only picking up the valvular calcification in and out of plane in the z-axis, but it's also avoiding the sinus calcification and the coronary calcification. So Ravi talked earlier about, how do we get rid of some of the tedium that we do on a daily, that's part of practice. That's hugely invaluable. Reducing the number of clicks, very rapidly being able to find only that calcium that's relevant to the score saves us a ton of time. So the tool is robust. It allows rapid, accurate quantification of valvular calcification and avoids the potential false positive of severe aortic stenosis by avoiding the inclusion of the non-contributory calcium. I often liken a lot of cardiovascular disease to plumbing. Either something's blocked or it's leaking. And angiography is largely what we're answering, independent of the vascular bed. The advent of and increased availability of gated thoracic aortic angiography has led to earlier detection and reproducible surveillance of aortopathies. It's also another area of growth we've noticed in our community partner institutions. Through our PAC system, people are getting more and more referrals for surveillance of aortopathies in our surrounding hospitals. And we, in addition to doing that surveillance in London, because of our cardiovascular footprint, are often looking at pre-surgical planning for these patients. Iliac femoral assessment. There's lots of different scenarios where this is actually being sent to us. This initially started back when the TAVI population started to creep up. 2008 is when our program started. And that's really largely driving, will the prosthesis and the associated catheters be able to go through the vascular bed? So a lot of that was sizing. How big is the lumen? Can we navigate the vessels to get up to where we need to get to? With the growth in minimally invasive surgeries across the board, no different in cardiac surgery, the need for retrograde cerebral perfusion. And it's actually fascinating when we started getting referrals for this. It wasn't clear to me exactly what they were looking for because we'd kind of come out of the TAVI world and we were measuring luminal diameters to tell them all these things. They said, oh, no, we don't need to know that. What we need to know, well, I mean, they sort of need to know that, but what was more relevant to them was plaque burden and tortuosity. Because, for those unfamiliar, this is an alternative to cardiopulmonary perfusion. So instead of actually putting cannulation sites in the ascending aorta and in the systemic venous side, it's called the atrium or the SVC or IVC, they can actually use either axillary cannulation or femoral cannulation. So if they're using femoral cannulation, they need to drive up the systemic perfusion from the groin up to the brain. So if there's plaque there, it's critical for them to know about that. So here's a prototypical example of aortic analysis. I've only picked 3 segments. So we often are actually giving 7 segments because those 7 segments drive the type of surgical intervention that will happen. And that's a fairly standardized template that comes from the surgical literature to drive, careful monitoring of each of those segments. So the image on the left is the ascending aorta. The middle image is just proximal to the brachiocephalic trunk, and the image on the right is just proximal to the left subclavian artery. If either of those segments are dilated, it'll change the type of surgical approach. It usually goes proximal to distal in terms of dilation. So if it's just the proximal, it would be an ascending aortic reconstruction. If you've got involvement of the proximal arch just near the brachiocephalic trunk, they may do a hemiarch reconstruction, and if you've got involvement of the arch near the subclavian, it may require either a total arch reconstruction or a staged procedure where the second procedure could be a TEVAR and a stent graft placed from femoral approach. Of course, this segmentation can only be as good as the CTA protocol, so optimization of tissue contrast is key to have seamless workflow. Another talk I could give on how we've achieved that using our wide volume CT. The curvilinear line on the right, and I should say actually, so a lot of people typically show curved MPRs. This is actually a straightened MPR from a curve using the centerline functionality. And one of the reasons I use this, and you'll see this for the iliofemoral example as well, is it helps generate this curved line on the right of each of these images. Very quickly, you can qualitatively see the luminal diameter of each of the different segments on whichever vessel you're looking at. So for the aorta, where you're looking for the maximum caliber, you can very quickly pick up where it's biggest, and that's where you can very quickly measure relevant sizes. Vitrea also allows the ability to not just measure within the lumen, but actually include the wall, and I'll show that in the next slide. But for the aorta, inclusion of the wall, and a lot of this literature comes from the abdominal aorta, less so from the thoracic aorta, where we don't tend to get as much wall plaque, but wall stress is a key feature in what we need to be able to assess. And if you exclude the wall, you're sort of underestimating the actual wall stress that would be there. It's a surrogate measure, but it is more accurate to include the wall. So here's an example of a straightened MPR for the iliofemoral vessels, again using centerline functionality. And in this case, we're actually using the lumen functionality. You can see below that, if we checked off wall, it would actually be able to include the wall in there as well. And so why is lumen diameter important? As I was mentioning earlier, for TAVI patients, if you've got a prosthesis that you're going to be feeding up those vessels, you really need to know the minimal luminal diameter. So unlike the aorta where we're looking for dilation, this is actually looking for the smallest caliber size. And I should add, actually, the other part of this that's really wonderful is the ability to save snapshots at any stage of this segmentation. So we've actually got our technologists, as the patients get off the table, saving snapshots for us, so that as radiologists, in terms of decreasing our involvement in the segmentation, we can really start off at this point and really look at that relevant luminal diameter to go straight to the report. So this example, the image on the left, which is the patient's right iliofemoral system, you can see just how dramatic the decrease in luminal caliber is. So we used to actually have thresholds when the TAVI program first started, and they said, well, we want to know this number, that number. Now, because of the plethora of devices that they use, we actually just provide the numbers and let them make their own sort of decision on it. The other nice thing, though, about this straightened MPR and volume rendered image together is it actually provides a really quick qualitative assessment of plaque burden and tortuosity, which are also important in the team trying to assess whether they can pass a catheter through that vascular tree, i.e., are they at risk for distal thromboembolism? Are they at risk for inducing an iatrogenic dissection in certain scenarios? Sorry, I'm not sure if I have a delay. There it is. I thought I would add this example to highlight similar utility for coronary assessment. Many cardiac radiologists, myself included, typically use manual MPRs with double oblique planes to interrogate coronary segments. sounds counterintuitive in this day and age. You're like, well, we've got all this fantastic segmentation software. Why are you doing things manually? I mean, the coronaries are very small vessels. There's a lot of artifact, although I guess if we get the 0.24 CT, we won't have to worry about this anymore. No, I was kidding. And unfortunately, it's still, talking about truth, sometimes you just don't believe curved NPRs, and you really want to interrogate those suspicious segments carefully, because it may or may not, if it's the only segment involved, it may or may not drive further downstream testing. So it's pretty important, I think, to do that. But this example is a great one in that it shows, akin to what I was showing for the aortic and the iliofemoral vessels, that this straightened NPR, if you look at on the right, you can very quickly see that there's two stenoses in the proximal LAD, which for sure, you know, still in my practice, I go and I make sure that I believe that in a manual mode. But this very quickly lets me actually identify potential stenoses without much delay. So pivoting away from our routine to the more advanced clinical scenarios, as well as some research. We don't typically use CT for myocardial function. It's really not a standard of care. Echocardiography is ubiquitous. It's pretty reasonable at doing it. If there's any adjudication, we go to MR. But there will be scenarios where the ability to do it on CT is actually useful. Obviously, there are scenarios with limited access to MR. That could be local. I know in some jurisdictions it may be the only way of quantifying it. Poor acoustic windows in echocardiography. And in early days, we were actually doing it for assessment of ARVC with patients who had already had their devices implanted and couldn't undergo an MR. Myocardial perfusion, this is an area of pretty much only research even to this day. There may be some institutions that are implementing it for clinical care, but largely this is being compared against the standard of care, which tends to be nuclear medicine perfusion, or as we've heard, FFRCT if you happen to be fortunate enough to have that tool available to you. And a theoretical ideal future state, of course, would be the ability to integrate both the epicardial flow dynamics with the myocardial perfusion with a rapid segmentation. And maybe that's a discussion we can have with folks here. So this is an example of the kind of output one can get from the myocardial function. So you can see that there are 3 volume curves generated, one for the LV, one for the RV, and one for the left atrium. The astute of you will notice that the ejection fraction of 3% from the left atrium is incorrect because they've picked the wrong diastolic and systolic phases, but that can be adjusted on the fly on the software. But what's nice about this is CT is extremely fast in terms of the acquisition side. This post-processing is also extremely fast. So if you've got access issues in getting somebody to quantify function, this is a very, very rapid tool. This is just an example of a rest and stressed perfusion, myocardial perfusion study. We don't do it at our institution, so this is really just for reference. But as I say, this could be a future state. As we've seen in care being driven in the acute stroke scenario, where the plumbing plus the end organ changes in terms of perfusion have led to some fairly rapid and robust advancements. If we could do the same thing for cardiac disease, it'd be a real game changer. And these tend to be stable patients with stable disease rather than the acute scenario. So it could really change the way management's happening right now, because the reality is that if although the standard is nuclear medicine perfusion study imaging, most people agree that there are too many false negatives and false positives there, and we really should be moving away from that in the long term. All right, so now switching gears to a truly fun part of my practice. Most people are familiar with volume rendering, sometimes referred to as surface shaded rendering. It's the standard volumetric 3D reconstructions that we've had for a long time. And the mathematics are much simpler than the alternative I'm about to show, in which each voxel is basically reconstructed using a single light ray. Global illumination rendering. sometimes referred to as cinematic rendering, offers photorealistic 3D visualization. So unlike the simple math, this gets much more complicated. We're tracing billions of photons coming from all directions to generate each voxel. That leads to lighting that is far more realistic and intuitive to the observer than the typical standard VR reconstruction. The term cinematic rendering actually comes to us from Hollywood or the movie industry, Pixar animation films, which my kids watched all of them when they came out. I don't think they watch them anymore. That's really what laid claim to there. And then those of you that game might know that it was originally called ray tracing and Tomb Raider. Anybody play Tomb Raider out there? Yeah, so Tomb Raider was one of the ones that was laid claim to, was famous for ray tracing to offer photorealistic environments in 3D gaming. So here's an example of someone with complex aortic surgery. They've had an ascending aortic reconstruction with a stent graft in the ascending aorta as well as the descending aorta. So we can compare the MIP image on the left, which is familiar, but sort of limited in the amount of information it's providing us. The volume rendered imaging in the middle certainly offers more detail, and a lot of this, I should say, is largely for our referring clinicians because it helps them visualize things. We're, as radiologists, obviously very used to seeing things in 2D planes, and as I said, still in the axial 2D plane for the most part. But when you show them something like that on the right, the endoleak between the ascending aortic graft and the descending aortic graft becomes far more obvious, and it's far nicer to look at and much more obvious as to what the anatomy is. So that's the white arrow near the level of the arch. That's an endoleak between the two grafts. Here's an example of an arteriovenous malformation at the upper pole of the left kidney. The imaging on both studies, the global illumination rendering on the left and the standard VR on the right, show the detail of the AVM, but it's a much more natural-looking representation using global illumination rendering on the left. And there's some data out there that, in fact, subjectively, the depth perception is actually improved with this. And again, for our clinical colleagues who are going to be using this to drive pre-surgical planning, this can be profoundly valuable. This is a case that I published with our surgical colleagues, a fascinating case. So the image on the left is just a 2D planar conventional cath, selective injection of the left internal thoracic artery. This is a patient who 20 years earlier had undergone CABG, single vessel CABG, and not just any single vessel CABG, robotic CABG, something that our center happens to do or has been doing for over 20 years. So you'll notice that this person, the image on the right is a global illumination rendered video. You'll notice that this person's left internal thoracic artery is now extrathoracic. It's actually protruded superficial to their left costochondral junction. Really amazing visualization of this unusual complication. What's particularly striking about how good this looks is this was done on our old 4 centimeter detector CT, not on our wide volume 16 centimeter detector. So Vitray is obviously still quite robust in being able to take even old data and manipulate it to the way you want to enhance visualization. As a last example, this is a case of a patient who required a mitral valve repair. So we've got standard grayscale MPR/MIPS on the left, and then we've got global illumination rendering on the right. The top row is pre-surgical, the bottom row is post-surgical. So the team actually was going to be challenged to repair this person's mitral valve because of the mitral annular calcification around the valve. So they actually went in and emulsified the mitral annular calcification, and you can see just how much more obvious and the richness of the information is using global illumination rendering to see that mitral annular calcification and know what they needed to emulsify in order to repair the valve. And the image on the bottom shows the repaired valve. the dramatic decrease in the mitral annular calcification that they emulsified. And if you look closely, which you can't see on the MIP image, there's the annuloplasty ring that's actually sitting at the mitral position as well. So in summary, Vitcher provides rapid, accurate post-processing for routine and advanced clinical cases and is available through our department. I should have mentioned it's a thin client install that not only do we have in our department for radiologists and technologists use, those of us with home stations can use it as well, and it makes, again, our workflow really quite easy in terms of the stuff that used to take quite a long time. Thank you.